Welcome to Heart Failure Unfiltered. My name is Nick Hartshorne-Evans and I'm the founder and CEO of the Pumping Marvellous Foundation, the UK's heart failure charity. Today, we'll be discussing when primary care heart failure training is not an optional extra, and this relates to our Marvellous Masterclass programme of events in the northwest of England. This podcast is about heart failure and why the simplest ideas often save the most lives. This podcast asks one question over and over again. Heart failure training in primary care is essential, not optional, because if care isn't adopted, it doesn't matter how clever it is. Heart failure affects over 1 million people in the UK. Its mortality exceeds that of many common cancers, and yet, unlike cancer, early recognition still depends heavily on the knowledge and confidence of primary care. Today, we're asking a simple, system-level question. Is investment in primary care heart failure education one of the most underused levers for improving cardiovascular outcomes across the NHS? So today I'm with a number of experts, and I think we'll start with, and it's in Liverpool Podcast Studios again, because they're our favourite podcast studios. Please, introduce yourself.
Hi everyone, Rajiv Sankanaran. I'm a heart failure cardiologist in Liverpool.
Hi, I'm Gavin Redder. I'm a patient educator with the Pumping Marvellous Foundation, and I'm a heart failure patient that's gone on to have a transplant.
So you've had the full...
I've been right through everything from diagnosis
cycle
through to transplant and post-transplant now.
Sue?
Hi, Sue Kemsley, GP of 30 years, working in Cheshire, GPSI in cardiology, clinical cardiology lead for Health Innovation North West Coast, and clinical primary care lead for the North West Coast Cardiac Network.
Thank you very much for joining us today. So we're going to be talking about heart failure and how it sits and impacts and sits in the strategy and the policy of the whole of the NHS. And in the long-term plan, it commits to earlier cardiovascular diagnosis. But where does heart failure sit in that priority? Rajiv?
Thanks. Broad question. I'll try keeping it concise. No, it's very relevant. So I'll keep it as concise as possible. So in terms of the NHS Long Term Plan, heart failure is a perfect example of how things need to change. You know, the three core elements that the government has talked about in the long-term plan or the 10-year plan, shifting from to a preventive element from a treatment element, shifting the diagnosis more towards the community rather than in a hospital setting. So those two core elements particularly affect heart failure pathways, and I think it's a great example of how we can change early diagnosis of heart failure and early management of heart failure to a community setting, but also preventing heart failure in the first place.
But how do we go and change the oil tanker? Because the oil tanker has been steaming for many years with all the investment in the acute, it seems to have all the investment in hospitals and the acute services. How do we go and push that out into primary? I remember these conversations 7 or 8 years ago.
It's about sort of rethinking the approach. And again, far too often we've been guilty of practicing in silos. The world's very territorial at the moment, but particularly the way healthcare is in terms of primary care, secondary care, and tertiary care. It's about breaking down those barriers and making it as seamless as possible for clinicians, for funding pathways, but also for patients who sort of go across these a variety of healthcare settings. So it's about bringing everything together and making sure that funding goes to where the patient is seen most. And primary care is the gateway for the patient. So it's very important that primary care is powered with enough funding, enough staffing to ensure that they're enabled to see these people and diagnose them promptly.
So Sue, what do you think?
Yeah, so we've got the NHS Long Term Plan, which was published in 2019, which talks a lot about prevention, and I think heart failure is tucked in there somewhere, without any explicit anythings really. And I think that's something difficult for commissioners, that there's no specifics. It's all quite vague, and that sort of runs to 2029. And in all those years, I haven't seen a whole lot of policy change in terms of the management of heart failure or the commissioning of it, which is why services are in the condition they're in. The Fit for the Future plan, published last summer, which is what Rajiv has been talking about, which is the move from firefighting to prevention, hospital setting to community, all makes perfect sense. And I think in the long term, if that's something we can achieve, then that is definitely the way forward. Again, in terms of the specifics, for heart failure specifically, it's not there in the detail. And if it's not in the detail, often then that doesn't get translated into commissioning services. In terms of the financing, I'm a very clinical doctor. I'm not a finance expert. But around 6 or 7% of the NHS budget goes into primary care. But 90% of activity is in primary care. So if we're going to have that shift, then something needs to change. The workforce in primary care, although has expanded, it's not in prescribers. So we've got social prescribers, physios, health coaches, dietitians, and they're all really, really helpful. But the prescribing workforce has diminished. And if you look at the per head of population GP numbers compared to, say, Europe, there is no comparison. We've tiny numbers, and it's been diminishing over time. So something needs to change. And with all these long-term conditions that we're looking after in a holistic way, which absolutely needs to happen, we need an expansion in that primary care workforce that's able to look at that clinical complexity, be a decision maker, and be able to prescribe.
Do you think this move towards these larger GP surgeries, moving more of the testing facilities, X-ray facilities going into GP surgeries, echoes, and other, do you think that will make a difference in terms of improving more, increasing rapid diagnosis?
Potentially, yeah, if we can get the pathways set up correctly. So nationally, the talk, of course, is about community diagnostic centres. And there are national guidelines on community diagnostic centres. And a lot of sort of the old cottage hospital sort of thing that does the X-rays and blood tests and things have now been labelled as community diagnostic centres. But if you look at what they actually provide, it's not really what you think it is. So when we talk about community diagnostic centres and exactly doing that, so, somebody has a beat screen, for example, and can then have a point of care NT-proBNP, perhaps, test X-ray if it's needed for whatever reason, and then first steps of treatment all in one place. That'd be great if we can get that in community diagnostic centres. But they're also quite spread out. And if you look at the geography of where they are, I've been looking at Langston, South Cumbria, particularly recently, patients are miles from community diagnostic centres. They're not community. They're not. And when you bear in mind heart failure patients are commonly the older, frailer, who can't travel very well, I think that needs to be thought through clearly in terms of what diagnostic hubs are.
There are still patients that are having the 24-hour monitors put on them, the ECG and then that has to be downloaded, it has to go to a specialist to be interpreted. So we still got that delay, whereas if we had the facilities and patients and somebody that could look at those results more rapidly, then that would make a difference, surely.
And it would cut out waste in the NHS. Not just for people that are attending all these multiple appointments, but
or failing to attend these appointments because they're based in a hospital setting with limited parking space. And like I said, it's about making sure that it's seamless for the person experiencing the condition, but also clinicians. Why should certain clinicians only work in a hospital-based setting? For things like ultrasound scans and things like that. So I think the important bit to recognize is we're not talking about shortcuts in terms of pathways. We're not making it too reductive. We're still making sure that the patient gets the best experience, the best outcomes, but sooner and in a place where they are, rather than out in one setting which is far from the community or the primary care.
Considering primary care is the gateway, the front door to the NHS, how can we use the masterclass training and its afterburn, which is after the events, how can we use that to reduce variation in knowledge? How can we improve that knowledge to try and manage that flow?
Yeah, I think it's two purposes. One is it sort of kickstarts a process, so it can't just be a one-off. It can't just be a one-day event with the impact restricted to that one day. So it's about empowering these people who attend on that day to cascade train, so the knowledge spreads from there. But like Sue was saying, a great example is to introduce these things in little segments. It could be in primary care segments. It could be on the screen for GPs and other primary care clinicians who see these people. It's about making sure that it kickstarts a process, but not just as a one-off event. And again, there are people who may not be able to attend on that day. So we need to think about, widening the scope of what we can do, and disseminating. A podcast is a good example, but there could be other ways of education which we can spread out from the masterclass.
But it's also you're talking about multiple aggregation of small wins, but lots of them, and the effect of that, rather than big hits here and there, and they deflate very quickly. But is the marvelous I was going to call it mentors. That's the one we did in 2018. God, the marvelous masterclasses. Do they tick the boxes of where the ICSs and ICBs are focused? Sue?
Crikey, that's a tricky question. Depends on where they're focused. Not all ICBs are focused on CVD, sadly. So that may or may not be true. I think the two that we're due to do in April, hopefully they are on the radar.
I think in this area.
In this area.
In the Northwest
absolutely.
Cardiovascular region.
It does support that. I think we have a job in those masterclasses to ignite some enthusiasm and motivation to improve outcomes in heart failure. And I think once you start to do that and get rid of that clinical fear about addressing heart failure and thinking about heart failure, then clinicians can start to learn and develop and disseminate it. So we need to empower in those classes.
So where we're trying to get to is early NT-proBNP testing, or I'd say actually early recognitions of signs and symptoms using the BEAT tool. The fact that there's early NT-proBNP testing, which is a simple blood test that rules out heart failure. It's very clear. Timely echo referral, because echoes are, I've heard some GPs talk to me and say, I feel sometimes it's not worth actually referring for an echo because it's months and months. And these people need to be seen. So it's that sort of conversation. And I suppose it's easier access and timely access to echoes, make it less friction orientated, take the friction out. Rapid initiation of disease modifying therapies, both in HFpEF, because we've got some potentially new ones coming up this year. The GLP-1s potentially a new MRA for PEF. So that's rapid initiation of that as much as the patient can take it, because we used to go low and slow, but now we do a bit faster because we get better outcomes. But not everybody can manage that. And then there's the admission avoidance as well. Reducing the hospital admissions, because I think in the over 65s in the UK, heart failure is the biggest issue in terms of readmissions and admissions into hospital, and where that, the old adage that's been going around and flying around heart failure seems to be ever since I've been doing it, is 80% of people get diagnosed in heart failure, yet 40% of those present in primary care with symptoms that would initiate an NT-proBNP and reduce that crazy admissions that patients have. So, what proportion of heart failure admissions then are potentially avoidable? Sue?
Probably around half, at least, are potentially avoidable.
Is that earlier optimization that help, or is it, what is it?
So prior to first diagnosis admissions, so people without a diagnosis of heart failure, potentially we could save around half of those by having that clinical curiosity to do an NT-proBNP.
And I could sort of give you a yes or no answer on, or you could give me a yes or no answer on this one, but do you think that clinician confidence, so not just GPs, but nurses and practice nurses and people seeing people with long-term conditions, because we know the long-term conditions that are on the radar, like type 2 diabetes, like high blood pressure, like AF, like obesity, are all potential contributors and risks to heart failure. Do you think that our marvellous events that we're going to do, the masterclasses, do you think they are a good way of impacting hospital admissions?
I do. I think, there's a big move in primary care to streamline holistic pathways for long-term condition management. And we know people with heart failure, number of long-term conditions that coexist are probably average around 4. So we're seeing patients with multiple long-term conditions at high risk of developing heart failure in general practice anyway, and doing regular annual reviews. And that there's no reason why we can't provide some motivation and education to instill the beat screen into those long-term condition reviews. And I think any clinician in primary care can do a beat screen. So it doesn't need to be a GP. So this breadth of workforce that we're seeing in primary care that are doing the long-term condition reviews all could be empowered to do that.
I mean, really, BEAT was developed for I would say, from my position and the charity's position, about the slight upskill that would make a massive difference to nurses who see patients on a regular basis just to take their bloods or just as an annual long-term condition check. So do we know what the costs are of delayed titration, Rajiv? Of optimization of guideline-directed medical therapies? Do we know what that costs us, or is that a bit finger in the air, or what?
Yeah, I think it's if you were to look at the cost from a healthcare perspective, it's very difficult to estimate. But from a patient perspective, if you take it, it's any hospitalization or decompensation as a result of delayed optimization or initiation. It's a very crucial inflection point, because you touched on admissions, isn't it? The hospitalization. So historically, it's been around 9-10 days, and during that period of time, it's not just the healthcare costs of around 400-500 pounds per day, of the hospitalization itself. The impact on the patient, the muscle wasting, the aging during those 10 days, it's crucial. And then you've got somebody who's far too unwell, and then they go back to a primary care or a community setting being unwell. So all those can be avoided through timely initiation and optimization. So I think it's a combined, but so it's not just the costs of that hospitalization, it's the wider ramifications of that hospitalization.
So I think the challenges are as we're talking. But Gav, would it be a good idea that every patient who got diagnosed with heart failure go through some form of formal, I'm not going to say mandatory or mandated training, but some form of self-management training to support primary care in
definitely
identifying and managing them?
If we can raise awareness, and once you get diagnosed, if you know what signs and symptoms you're looking for, so before about self-management, part of that process. I mean, Rajiv was talking about hospitalizations there, and I was one of those cases. I delayed initially the diagnosis. Once I got my diagnosis, I wasn't up titrated. I got fluid overload and I was straight into hospital, IV furosemide, try and get rid of the fluid, get me back out. But even then, I was told I would get a referral to the heart failure nurse. That didn't happen, so I chased it up myself. I'm proactive, advocate for people, so I went out there and made that referral myself. They hadn't received the referral. So there's lots of blips in the system. But in terms of self-management, I mean, we're moving to a model now where we're looking at virtual wards, we're looking at heart failure at home, those things. So there is going to be a need for patients to be part of that self-management. They're going to have to do those things. I mean, I had an ICD and the ICD picked up when I went into AF, it picked up that I was having wider issues when I went into advanced heart failure. So there's lots of tools and techniques that we can introduce that would aid clinicians to manage your heart failure much better. But we've got to be part of that process as well. And I think having patient educators like myself as part of this process and as part of those future masterclasses, I think it will have as big an impact as seeing an acronym just pop up on your screensaver or whatever.
So the average tariff is what, £400 to £500 a night at the NHS Hilton? Yeah, and it's a 10-day median stay. So you're looking at...
I think it's more than that.
It could be.
£800, doesn't it?
That makes it even worse. So my question, God blimey, I'll have to rejig my head. Is education cheaper than admission?
I should have thought so.
Yeah?
Absolutely. We do have the National Diabetes Prevention Programme, I don't think that mentions heart failure as being a risk.
I mean,
so there's other opportunities as well of education already.
If you look at the FAST, which is the stroke acronym, I had a stroke, and it was immediately obvious to me when I was having my stroke, what was happening, because I had the classic symptoms. And that was because that was on TV. It was the raised awareness. I've never seen BEAT on TV. It's never made it out into No, I mean, Nick and I have done sort of radio programs where we've talked about it, and it's like news to everybody that hears it. They're not aware of it. So we need to get BEAT as a mainstream sort of awareness-raising campaign across the general public as well as clinicians.
And it's a good point you make. So the impact of that, we have seen BEAT thanks to Pumping Marvellous, the campaign, BEAT on several advertising screens in Liverpool, London, etc. And that's directly had an impact in terms of earlier diagnosis. We've seen people ring up and say it was BEAT that prompted them. So there is a direct impact to that, and making it more widespread, making it more mainstream, television, social media.
I think we've got to manage our expectations here that we can't get everybody to do it. No. So if let's pull a percentage out, let's say 30% of people know about heart failure. If on a population level, if we can get 40% of people knowing about heart failure, 10% is huge on a population level. So it's just got to keep going and keep trundling away.
How about the NHS app? Heavily promoted now. Good way to raise awareness.
I was talking to my mother the other day about her blood tests, which actually identified that she was she needed to further her test investigations around iron deficiency. Everything else was good. But there you go, technology. And my mum, sorry if you're listening. I may not tell you about this one, but she's 80 and all right, she's pretty IT literate, but that's how the app can help her. Certainly with a relative talking through, some things that she may be unsure about, or what she needs to do in the case of needs further test investigations. So, question: Can training, can structured education improve the adherence to NICE guidelines? Who wants to take that one?
Yeah, so again, the awareness of the guidelines in the first place. Not as many people are aware of the existing 2 and 6 week pathway, which has been there for a decade or more, isn't it? In terms of from the NT-proBNP, what is the upstream impact? When should patient get a timely echo and a specialist assessment? So just simple awareness of that, awareness of the NT-proBNP, like we said. So it'll help people, adhere to these guidelines. Guidelines are guidelines. They exist for a guidance, essentially. But I think making it standardized as opposed to an ad hoc approach, it sort of eliminates some of the disparity in care that people are facing as well.
But people always say guidance, won't they? Oh, it's just guidance.
Yeah, it is. But there is a reason, and they've been developed on the basis of evidence, because the delays, and Sue alluded to a cancer 2-week pathway, for example, and it's very, very similar. So when you have someone with an NT-proBNP in the community setting of greater than 2,000, their outcomes are very, very poor if they don't have that timely specialist assessment, diagnosis, and initiation of therapies. And that's exactly how they were developed. So making that sort of widespread in terms of knowledge and education, where all the healthcare providers across the breadth in primary care, it could be a practice nurse, it could be a pharmacist, making them all aware of these 2-week, 6-week rules and the reason they exist. That'll go a long, long way, I think.
So do we have patients who, I know I'm one of them, who have a heart failure reduced ejection fraction diagnosis but aren't on the 4 pillars?
I'm sure we absolutely do.
But how do we drive that conversation? Can we drive that through education and training?
Yeah, so again, highlighting that there are these 4 pillars. There's cardiac rehab. So now there's, like Sue was saying, 2 decades back, we didn't have all these treatments available. But now we have these treatments available. It's about making people aware. And it could be the patient themselves. They could be asking, why am I not on this medication? So making them aware. Gavin is a perfect example of that awareness and spreading that. But also equally, it could be, like I said, it could be a pharmacist coming across this and saying, why is this patient not on the 4th pillar? Why have they not had cardiac rehab yet? So it's about spreading that awareness. And these are simple steps. And the Marvellous Masterclass project is something that will hopefully kickstart that. But like I said, it shouldn't be a one-off.
So could we standardize training, heart failure training, right across all teams? Make it really simple?
I think so.
And impactful?
Absolutely.
What would that include?
everything of the above that we've just discussed.
That was like an open question.
You want another great long
a little bit more.
It needs to start with prevention, doesn't it? So we're identifying people with high CVD risk all the time in general practice. And as I say, there's no reason why we can't embed it in there. But so education needs to go right across that life course of a patient with heart failure. It needs to touch on all of those points. I don't necessarily think primary care need all the details of how a cardiac transplant's done or the intricacies of cardiac devices. In fact, that's a way to switch primary care off.
I think you're right. Absolutely right.
We need to make it relevant and useful. And I think applying it to patients sounds stupid, but just having a dry meeting and saying, this is heart failure, this is what the treatment, it's not as meaningful. I think applying it to patient cases, having patients to support it, I think is absolutely vital.
I mean, for me as well, I think it's having a simple, understandable definition of heart failure. So that if I went into any GP surgery and saw a nurse, saw a GP, if I said, I think I'm suffering from heart failure, they should be able to say, well, heart failure is this. There is a very clinical definition of what heart failure is, but just knowing it's a pump problem and that your organs aren't getting sufficient blood and oxygen, etc., and that affects your organs. So if people had that very simple understanding of what it is at that very basic level, that's the minimum that the standardising, everybody should understand the definition of heart failure. And then moving on to what Rajiv was saying is then understanding what the pathway is, what the next steps are, and how rapidly that's changing in terms of up titration and rapid interventions.
And I think the shared responsibility as well. So like you were saying, so these people with a diagnosis, it's a long-term condition. They can see different clinicians at different points in time, but making every patient contact count. So when they come across a pharmacist, for example, that is an opportunity where if they're not on the right treatment, they can, a treatment can be added. If they're feeling unwell, so looking at their ankles, for example, it could be a simple thing. If they have swelling of the ankles, that's a sign that they're putting on excess fluid, and that can happen before they get breathless. So making every patient contact count in a primary care setting and a secondary care setting, I think that'll go a long way in terms of highlighting to people at these masterclass events, saying look out for these signs that these patients could have heart failure, even if they've got a pre-existing diagnosis. It's about making every patient contact count.
So there are huge benefits across. Sorry, no, crack on.
Sorry, can I just add as well? I think the primary care education is absolutely vital because obviously of a number of people we have on our list with heart failure and the number we have that we don't know have got heart failure. But the education needs to be right across the NHS. Heart failure patients have other conditions and are seen by other specialists, non-cardiac specialists, and sometimes get the wrong messages. For example, I think I had a patient who had an echo pre-op orthopedic intervention, whatever reason, and the specialist said, well, the echo's normal. You don't need your treatment. You can stop your medication. The patient came to see me. It's okay, I didn't stop it because you told me not to.
Right.
But many patients will stop medication if a specialist has told them that they can. Because they don't want to take, people often don't want to take medications, do they, understandably. So the message has to be correct right across the healthcare system. It's difficult for primary care to push that message if a specialist has told them otherwise.
And that happens a lot, doesn't it, with when people go into crashing decompensated heart failure, in other words, are very breathless, basically, and filled with fluid, and they arrive at the front doors of the hospital and their bloods are taken and they get whipped off stuff and... Who initiates that? I've always asked myself who actually initiates that patient to go back on those medications, because the chances are the patient won't, because they don't. They've been told time and time again, don't change your medication, and if you get them taken off them, and I get that, the kidney conversation, with some of the medications, but it's a big challenge. But I think the benefits of I think we clearly identified the benefits of primary care education. And I introduced education and training because training and education are different. Huge benefit to patients, huge benefits to improving the mortality aspects of heart failure, and huge benefits to the cost of doing business in heart failure. In other words, the admission costs and everything like that. But also we need to look at, does it benefit workforce resilience? Of course it does. Does it reduce clinical risks? Of course it does. And at the end of the day, it's better quality. And the quality assurance is there. So, Sue, what's stopping us from upscaling or scaling the Marvellous Masterclass program across the NHS? What's stopping us?
I mean, obviously money, workforce time to attend it, the fact that we've got too much work to do. It's not mandatory.
True that.
And the GP curriculum's huge, and we've all got different priorities.
So therefore heart failure is not a priority, is it?
So...
Or is it about...
It does depend on your priorities. And so GPs have, I think, usually 5 training days per year. So if you're going to keep up with your clinical education, what education are you going to choose to do?
How do you pick from the 100?
We have all the mandatory training that I've explained to you, deprivation of liberty and capacity training. That takes hours. So that 5 days is very quickly swamped. And there will be other clinical needs, of course. Mm-hmm. So how do you ensure that every GP decides heart failure is on their priority list?
Is this where GPSIs come in? That you have a dedicated GP within that surgery that are dealing with the cardiology?
Or within the PCN?
So, yeah.
So I think, I talked earlier about, when I came into medicine, heart failure there's no treatment really and no tests and no nothing. And it's really expanded in terms of what we can do, thankfully. But that's true of many other conditions as well. So how do you then ensure that all GPs know all of that all of the time? I mean, the answer is you can't really. So I think the time has probably come in the NHS for another tier. And I think GPSIs, I know this sounds like I'm promoting obviously what I've done, but I think GPSIs or clinicians with special interests, like we've enrolled the clinical pharmacists in our region in the heart failure diploma, upskilling some of the clinical workforce, not necessarily GPs, who are able then to have that life course approach to heart failure management. So somebody within each PCN, for example, or a neighbourhood team, or however you want to structure it, but possibly not every clinician needs to know absolutely everything.
It's almost about creating that pyramid model where everybody gets the bottom layer of education and training, and then the more advanced you get, you go up, don't you? And you hit that peak.
Or the more specialist.
Yeah. So everybody gets a basic level of understanding of what heart failure is and what needs to happen next. But there is that next level up, and that's where the challenge probably comes once you get above that initial level.
And actually, GPSIs and our clinical pharmacists that we've taken through the diploma, there is currently no career progression, there's currently no funding, there's currently no structure or governance for that. So that's a whole another issue that needs to be considered.
Rajiv, short perspective?
Short will be difficult, but let me, we're in the...
Give it a go.
Home of football, Liverpool. Yeah, but working in the NHS, it's like not having enough subs and playing extra time. It's like that. There's not enough staff, but it's making sure, like you said, the staff are recognized, for the training that they do. It could be GPSIs, it could be more heart failure nurses having that reach into the community setting. Yeah. So if you have a practice who have an assigned heart failure nurse for support, that will go a long way. It could be a heart failure trained pharmacist. So it's about making sure that the breadth of the multidisciplinary team that we have in all these care settings, in the hospital, but also in the community and primary care settings, they are valued for their time, their expertise, because once they have their upskilling through these programs, it's important that they're recognized for what they're doing as well.
Yeah.
And have time given to do that. So to do GPSI qualification, it's a very significant chunk of time.
Yep.
I was lucky that I was in the right time, right place, got the funding. Manchester Cardiac Network actually funded me. The practice freed me up to do the training. Most clinicians wouldn't get access to that, so I was lucky.
So the closing statement, which I'd like to leave with the listeners, is we cannot reduce cardiovascular mortality without strengthening the front door of the NHS. And that doesn't have to be necessarily GP surgeries. That's the whole gamut. That's pharmacies, local community pharmacies. We've been hearing on the news the demise of the community pharmacy over the past number of years, pre-COVID as well. And primary care education in heart failure is not a training issue, but it's a system redesign opportunity. And I think that very much plays into what Sue was sort of talking about. And the question isn't whether we can afford to invest in knowledge, it's whether we can't or we can not afford to invest in knowledge. That makes sense. I think I got that one right. Right, anyway, quickly move on. Thank you very much, and we appreciate you listening.